it is my great honor and my pleasure to hand over to Professor Philippe Bijlenga, who is a neurosurgeon at the Geneva University Hospital in Switzerland. He's specialized in neurosurgical pathologies, in particular brain vessel lesions and skull lesions. He's also involved in several projects to improve the safety of neurosurgery procedures and advance standards of care. Professor Bijlenga, may I hand over to you?
Thank you very much. Thank you very much for Leica for giving us the opportunity to share our experience. And thank you to Raphael Gutzman also that actually announced very clearly this session. So I will talk about the use of GLOW800 in aneurysm surgery and AVM surgery. I will first discuss about the particularities of neurovascular surgery, enhancing that neurovascular surgery most of the time is an extra-cerebral surgery, so it should preserve the brain. You know that vessels are routing all around the brain and inside the brain, and they're essential to feed the brain, and those structures need to be preserved. And if you need to occlude them, then the time is kicking and the occlusion time is limited. Also, nowadays we know that we have maybe more time than we think. So a quick review of what neurovascular surgery is. Most of the time we treat intracranial aneurysms. Just to recall, intracranial aneurysm is a very prevalent disease. 3% of the population is affected or may be affected. But the issue with aneurysm most of the time is the rupture of the aneurysm, which is a very rare event and affects a little bit less than 5 per 100,000 inhabitants a year in Switzerland. We always say it's between 4 and 10 per 100 inhabitants a year, according to the different regions in the globe. The second disease that we manage is cerebrovascular arteriovenous malformation. Those are much less prevalent. We usually say it's between 10 and 100 times less prevalent. But it seems that this disease is more severe for affected people, with a risk of rupture also, which is approximately the same frequency as intracranial aneurysm, so around 3.6 per 100 inhabitants a year. And then I think there was already a session on dural fistulas, or even 2 sessions on dural fistulas. This is an even rarer disease, which is affecting 2 per 10,000 inhabitants. And the issue here is more kind of ischemia, or there might be symptoms of edema. And the incidence of issues is very rare. So this is a disease that every center sees maybe a few times a year. And finally, the intracranial steno-occlusive diseases, which are extremely rare, more prevalent in Asia than in the Western world. And here we are talking about, for example, moyamoya disease, and this is usually a few cases a year in high-volume centers. So how do we treat those anomalies? Well, there are many techniques, and I think that over time we are producing more and more tools to actually manage those diseases. And there is typically surgery on one side, endovascular on the other, or radiosurgery, and all techniques need to be customized for each patient. So today we will mainly talk about the clipping of intracranial aneurysms, about the resection of cerebral arteriovenous malformations, about the clipping of dural fistula, and I will show how we use GLOW800 for revascularization in moyamoya case. So now we benefit from a long history of surgery of cerebrovascular diseases. I think that big changes have been made with Yazagil describing the use of the microsurgical microscope and usage of clips to actually clip those aneurysms. And he described the technique where we actually clip the aneurysm and remove the aneurysm dome to be checking visually around the clipping to be sure that we have no dog ear on one side and that we didn't clip inadvertently any perforator that could actually lead to an ischemia and to neurological deficits to the patient. From that ground, many techniques have been developed to improve the quality and to improve the safety of this procedure. And endoscope has been introduced to actually check behind the aneurysm to be able to see if we can check in the dark angles of the operating field. The next step forward has been the use of the microvascular Doppler, so a very small probe you can put on the vessels that allows to listen to the blood in the vessels and verify that there is a good perfusion in all the branches and that there is no turbulences coming from a stenosis. Later on, there has been the innovation using indocyanine green, which was widely and is widely used in ophthalmology to look at the vessels in the retina, and using near-infrared video angiography to actually visualize the flow of the dye in the vessels. And this was a breakthrough to actually visualize the flow in the vessels and check first that the aneurysm is excluded, and then that all the perforators, the very tiny perforators, are well perfused. The next step has been to add augmented reality to actually improve the minimally invasive approaches to actually displace the brain as little as possible. And before we do any action, being able to see through the vessels, have a good representation of the anatomy to actually adjust the clip as precisely as possible and avoid all the small vessels that could be hidden behind by any other structure. A sixth step has been to introduce and combine endoscope and indocyanine green and use the ability to visualize the vessels with indocyanine green and look behind the aneurysms with endoscope. The issue we have with indocyanine green is that this is a near infrared. So you need to have a camera and you need to display the images on the screen. And you need therefore to get your eyes out of the operating field, and you need to imagine the structures, recognize the structures. So the idea here of this seventh innovation is to actually get the video image back in the ocular pieces so that actually you can overlay on the visual field the fluorescence image. And this has been called DIVA. And it's more or less the similar things that we do with GLOW800, meaning that the black and white image from the infrared camera is transformed in a false color and superimposed on the operating field, overlaid on the operating field. So you actually not only see the vessels glowing, you don't see only the dye, but you see where, and you can easily recognize which structure is perfused and which is not. More recently, we have been improving the control, and I think every neurosurgery needs to be checked, and we need to have an imaging that assures the surgeon he achieved the aims he actually targeted, and therefore we have the opportunity to work in hybrid rooms, meaning that we can do an angiogram during the surgery and have a replicate, a digital replicate, 3D replicate of the vasculature of the patient and check if there is no dog ear left and check if all the vessels are properly preserved. And then I was quite surprised to see that neuromonitoring has been demonstrated as a very efficient tool to reduce the complications. Only very recently, neuromonitoring is recording the function of the patient, the sensitive motor function of the patient, and maybe also visual field cranial nerves, so we can monitor the activity and the function of the brain during the operation. And this can warn us if we are injuring the patient by too much compression on the brain structure, or if we are producing an ischemic injury because of an inadvertent closure of a vessel. So those are all the tools that a neurosurgeon nowadays has available to minimize the invasiveness of his procedure and increase the safety of the procedure. Now, those different tools have all pros and cons. So the direct puncture of the aneurysm, the resection of the aneurysm, is extremely reliable. Means that you know if it bleeds that you didn't clip correctly, but it's scary. Most of the people, most of the surgeons are scared to cut the dome out because they might lose the control. If they need to have a re-clipping, they have an open hole in the vessel. So actually very few surgeons still do it. The endoscope is very rapid. It reduces dead angles, but it's bulky. And actually, even it reduces the dead angles, it doesn't remove dead angles. So you might still have some aspects, some places where you don't understand or you don't see the anatomy properly. The microdoppler is also very easy and very rapid, but is subject to specificity and sensitivity issues. You need to be experienced to actually understand the noise you hear on. And sometimes you might have signals from another vessel which is close by. So here again, you might be sometimes misinterpreting the signals. ICG, near-infrared angiography, is rapid, very easy and sensitive. It's widely used, but you have dark angles and you work in the dark, meaning that you have only vessels and all the other structures are black. So you need to represent yourself and you need to recognize the structures. Augmented reality facilitated approaches and clipping, but it's not live information. This is pre-recorded information, which is overlaid, so it has no impact on the result of your surgery. Combining endoscope and ICG angiography is all the same benefits of near-infrared angiography and endoscopes, but it's still bulky, and you still have some dead angles, and sometimes in the black and white image, it's difficult to understand the structures you're looking at and having a proper assessment and interpretation. So combining the black and white image with the white light image in the dual image video angiography or GLOW technology allows to correct for this black and white image and allows a better orientation. So it has good pros, but the issue is that you might have some issues I'm going to discuss about sensitivity, about dark angles, and about some shadow effects, and about the magnification. I will come into more details. Hybrid room angiography has no dead angle. It's a 3D replicate, so I think this is the gold standard to control the cerebrovascular anatomy once you worked. The issue is that it takes time. It's quite expensive to have a hybrid room and maintain it. So not every center has access to a hybrid room angiography. And neuromonitoring is sensitive, but it doesn't tell you where the problem is. It tells you, it warns you that you're facing an issue, that the brain is suffering, that something is not working, but it doesn't tell you where. So you need to have a possibility to visualize the injury. So the tools we use in Geneva is a combination of all that. So we work in a hybrid room environment. We have neuromonitoring. We have neuronavigation with augmented reality. And we use the Leica microscope with near-infrared images, with the GLOW800 augmented reality, and readapted navigation. This is our procedure. We published in How I Do It quite a while ago, is that we plan the procedure with the residents. It's a good way to teach. So we look at the angiogram in 3D and we rotate it to actually have a projection corresponding to the operating field, the surgical point of view. And then we identify all the vessels we will use as guides to guide us towards the lesion. And then we look at the lesion and we think about how we're going to clip. We look at the size of the clip we're going to use, and we have a plan on all the different options we have to clip here 1 or 2 aneurysms. And once we realize the surgery, once we perform the surgery, we use, once we clipped ICG, and we look at the fluorescence, the way it's glowing up, and we know where we're going to see one or the other branches. So here we have in dark green and in light green the inferior trunk and the superior trunk, and we know that if something is not glowing at the right time, we know which vessel it is. And then we do the 3D rotational angiogram intraoperatively, and we can see the clips, and we can see eventually remnants or dog ears, and we're extremely stringent to actually leave no abnormal residues. And here you see the very small red angles. We actually added a few clips. We prefer to have a slight stenosis, which has no effect on the flow, we can see on the angiogram, than having a remnant remaining. So the way we do everything is plan, monitor, verify, and seek for perfection. On that procedure, we added augmented reality. And here what we do is we readjust the navigation. So the navigation is registered to the patient, and then we project, before we drape, the face, the virtual face of the patient on the top of the real face of the patient, and we see if the model is perfectly adjusted to the reality. And we have an option allowing to readjust it very precisely. Then we prepare the craniotomy, and we actually look, before we do the craniotomy, on the angle, and we look on the sylvian fissure, and we actually decide what's going to be the center of our operating trajectory, and we check what are the optimal craniotomy we have to perform to actually have a comfortable approach to the aneurysm. So here there is a kind of balance between a tiny craniotomy and a too tiny craniotomy. So we want to have comfort, but we want to protect the brain, and we want to reduce the retraction as much as possible. And here, again, we use bony landmarks to readjust the navigation to be sure that it's accurate. Then we use the vessels as guide, and we actually project the segmented vessel or models on top of the real vessels, and we can see that it adjusts pretty well. And then we mark, before the surgery, the neck of the aneurysm, and then we adjust, like on the lower middle image, you can see the clip holder and the clip, which is overlaid with the green dots representing the neck of the aneurysm, and we align that so we can actually clip. And once we clipped, we do a video angiography to check very quickly if the main vessels are patent or not. And then we do a 3D angiogram to check the overall 3D geometry for any remnants or stenosis. So that's another way. This is a small video I'm going to run where you see an aneurysm and you see how we orient the angiography so you can actually project yourself in the operation prior to the operation. So you see that we rotate, we look all around the aneurysm, we look for all small vessels that may need to be dissected off or that may be close to the neck, so we can actually mentally remember all the difficulties we might have. Then we define an optimal position trajectory that the patient is going to be positioned in. And here you see how we project the augmented reality to see the aneurysm dome. Now you see that we know where the neck is, and we put a clip on the neck. We use a lasage clip, which allow almost an endoscopic approach. We like because we have no bulky clip holder around. And then we do video angiography, and we look at the branches. And you see that we use as little as possible retractors. Now, I highly recommend that even so we have GLOW800 that allows to see the vessels in green overlaid over the visual field, to look on the black and white image, because it's still more sensitive. And as Yazegil demonstrated, we remove the dome, we coagulate, so we can actually visually check again that everything is properly clipped. And we may even do again a GLOW800 when we exposed everything, so we can check that the vessels are nicely perfused. So that was just a first example. And you see the difference between the GLOW800, where you understand what you see, you understand where, but still the very tiny perforated, the very small vessels, you see them better in the black and white FL mode. And then we do the angiogram, we check the clipping, and if we're happy, we proceed to the end of the surgery. If we're not happy, we then continue by replacing the clip in another position. So we published our experience using augmented reality and monitoring, and here is our experience adding GLOW on top of the previous protocol. So we now have 28 cases we operated on, and we had some issues. So all patients were operated with augmented reality monitoring and 3D angiograms. We used GLOW800 in 28 cases. We learned to use FL800, and it was needed in 7 cases. And we actually needed to reclip once we checked in 3 cases. Now, the reason for the need of FL800 is because we had shadows, and I will get into the details about what is the shadow effect, what is the problem of the shadow. We had issues with very tiny perforators, very small vessels, where we could actually not see the green signal on top of the small vessel. And we sometimes had 2 weak signals in GLOW800 mode, but that was not a problem then switching to FL mode. So this is a case of a case where we needed to reclip. So you see the clip is, the vessels are very thick, they're very tiny. This is a Sylvian bifurcation. And we clipped, but the clip was producing a stenosis of both branches. And you see here very nicely, the dye is coming to the bifurcation, but it doesn't perfuse the branches. Then we reclipped, and then you see that the branches are nicely perfused. And you see that the aneurysm is not perfused. Despite seeing no fluorescence in the aneurysm dome, we tend always to puncture the dome to be 100% sure, and to remove the dome if he is hiding anything and needs an exposure. This is an example of a case where we were confronted to the shadow effect, and I explain you what we were facing. So here you see the branches are nicely getting green, but you don't see on the top of the image, on top of the clip, there is another artery in the depth, and we don't see that artery now. But now we turn around, and on the tip of the aspiration, now we'll go expose it with, and you see here this small vessel, which is between the aspirator and the bipolar, is now green. But we were not able to see that, and if the temporal lobe is over it, the emission light is cut out of the field, of the operating field, and there is no excitation or very little excitation of the fluorescent agent, and you're not able to see the vessel. This effect is reduced when you go in black and white. You can see the vessel here, but you see it much brighter when you remove the temporal lobe. So when you work in very confined environment, you might have this shadow effect that doesn't allow to see the fluorescence of the vessel. And this problem is actually less a problem when you are in the black and white mode, because you have a much stronger contrast between the black and the white. Now, this is another case where we had a very small perforated. This was a choroidal artery aneurysm, and there was a very small choroidal artery which was just close to the clip, and we really wanted to know if this artery was perfused or not. And by running the video, you will see that we magnified quite a lot to see the small perforator. And you see that between the dissector and the aspiration, I'm exposing that small vessel, and I'm waiting for the fluorescence, and nothing appears. And I'm asking the anesthesiology, did you give the ICG? I don't see anything. Then I decrease the magnification, and you see that actually the dye has run already, but you didn't see anything. So if you over magnify, what happens is that you don't have enough light excitation, and the fluorescence is too tiny to be seen. So you need always to respect the specification given by Leica and not over magnify. But in FL mode, you can see very nicely the vessel here. You can see this white line between. So in FL mode is less subject to this magnification problem. The other thing is that sometimes the green or the blue or the red overlay of the fluorescence on top of a white vessel makes that the white light reflection from the vessel is too strong to actually see and have a contrast which is sufficient to see the signal. So be always careful when you look at white vessels, because the overlay might be difficult to perceive. So that was what we experienced with aneurysm clipping, and I must say we're overall very happy, and it's really changing our workflow and increasing the safety of the procedure. Now, AVMs. AVMs needs to be studied before we do the surgery, and we need to identify the veins, because we want to avoid the veins. We need to find out ectasies or aneurysms to avoid them during the surgery, not to be facing a premature rupture. We also need to identify en passant vessel. In the middle here, just over the nidal aneurysm label, you have a vessel that is crossing the full AVM from left to right, and it's called en passant artery. And this vessel is actually nourishing, feeding the AVM, but it's also feeding normal brain. So if you sacrifice that vessel, you are, or the patient is unlucky and is likely to actually suffer a stroke. So you need to preserve those en passant vessels, en passant arteries. Then you need to study the feeders, and if you can actually shut down the feeders before you actually start removing the AVM, then the level of security, the level of comfort, of surgical comfort is strongly improved. Therefore, it's always nice to remember precisely where you can actually access the feeders and maybe shut down the feeders. So we always look for proximal points of control. And finally, I was taught to always check when planning the operation, relationship of the tip of this carotid shape of AVM with the ventricles. And very often there is some interaction with periventricular vessels, mainly veins, that sometimes at the end of surgery are a little bit a pain to coagulate. Now, again, we published how we use augmented reality to facilitate AVM surgery, and this is something we use a lot. It allows to customize the craniotomy. It allows to correct for navigation inaccuracies, and allows to find the en passant vessels, and it allows to identify, as I will show you later on, the points of proximal control. And you actually are an educated surgeon, because when you approach the AVM, you have a good representation of the 3D shape of the aneurysm of the AVM in the context of the patient's head during the operation. So that's typically the procedure we follow for all navigated and all augmented reality surgery. We first check that the model of the patient is correctly adjusted with the patient's head. Therefore, we use the eyebrow, the nose, and the ear. And then we look at the 3D representation. Here we are just showing how we scan up and down to check that the suture here are correctly adjusted. And then here again, we're approaching the AVM. And you see the green dots are actually the dots where we plan to do proximal control. So we're going to first open the arachnoid in front of those points to put a clip to shut down the AVM. Here you see the first injection of ICG with GLOW to actually visualize the flow of the blood through the feeders, the AVM, and see how quickly it goes. And then here we're addressing the first point of proximal control with a tiny clip. Then we go to the second one. And in that particular AVM, there was 4 feeders. So we are able to clip 3. There is one which is going to be accessible later on. And you see already here before and after the clipping, the influence we have on the flow in the AVM. Again, here before and after the clipping in FL mode. And you see that the flow is highly reduced in the AVM. You see that even the flow is turbulent in the drainage vein. Here we are actually starting the resection of the AVM, accessing to the fourth feeder. We're going to expose. And here we are arriving to this fourth feeder. We're going to coagulate and cut. And you see that we can actually perform very dry surgery. And I think a dry surgery allowed the surgeons to keep a very good control of his dissection plan and improve the safety of the surgery. Here, we disconnected completely the AVM. It's completely deflated. We coagulate some venous outflow, and we're going to coagulate the principal drainage vein, cut it out, and the AVM is going to be removed. We usually like to cut, but sometimes the vein is so now we actually add ICG, and you see that the cortex is getting fluorescent, and you see that in the resection bed, there is no fluorescence anymore, meaning that there is no remnant. We always look again on the FL mode because it's more sensitive, and you see that there is nothing, and we end up doing an angiogram. So we do here projection, different projection to see at the flow and to look for an early drainage vein, and then we might do a 3D angiogram to actually check there is no remnant at all, even in 3D representation. So timing of the flow is essential when we do AVM surgery. So what you see here is that we define T0 when we start to see a little bit of contrast in the artery, in an artery. And then we look, and usually we should not see the veins getting fluorescent before 4 seconds. If we see it earlier than 4 seconds, it means that there is a shunt, and we use that as a tool to see if we already devascularized or not the AVM. Here you have the model of the AVM on the right, on the bottom right, and what you can see in yellow is the artery feeding, or one of the artery feeding the AVM. In pink is the drainage vein, and in red is the nidus. And what we plan to do is to put a clip just proximal on the yellow vessel and look the effect it has on the timing of the fluorescence. And what you see here is we put the clip on the artery, and you see in light green that the temporal aspect of the arteries are perfused early, that the frontal aspect of the artery with the light brown arrow is not fluorescent anymore. And you see that the draining vein is remaining not fluorescent even after 4 seconds. And you see that there's another feeder because another aspect of the vein, which is more temporal, is actually getting green. So you know here that we partially devascularize the AVM. So that's another example where you can see the ICG and the glow of the AVM. And that's the first. And this is now after clipping. And you see that we completely change the flow of the AVM. And when we see such a reduction of flow, we know that the surgery of the AVM is going to be much easier. So we currently operated 8 patients with GLOW800 and AVM surgery, always using augmented reality and the 3D angio. We actually never really needed the FL mode. We always used the FL mode to check at the end, but we never really needed it. We never had a bad experience seeing something in Flow 800 we never saw in GLOW as we had for aneurysms. We used it 6 times to have a nice confirmation of the proximal control, and it helped correcting for missing branch or identifying feeders in 2 cases. So it's true that in AVM, you have a complex network of vessels, and the ability to identify where the fluorescence is in the real anatomy facilitates greatly the surgery. Now, here I'm going to be very brief about dural fistula, but I wanted to show that we used it for dural fistulas too. Again, we use augmented reality to find the fistulous point. You have here, this is not the topic today, but you saw very quickly in blue the augmented reality that allowed us to identify the fistulous point. Now we see here the vessel, we inject, and we look for fluorescence in the draining vein, which are shown on the top of the screen. Here we put a small Leica clip on the draining vein. We put it usually distally and proximally. We coagulate and then we cut. And then we do again an ICG injection and we check the flow in the vein and we look for stagnant flow. So we look for a very deep, very venous phase flow and a very stagnant flow or slow flow. We sometimes also use Doppler to confirm the good exclusion of the fistula. So here you see that we put the ICG, and you're going to see that tortuous vein is getting very slowly fluorescent, and you see that there is some stagnation. And again, we understand the anatomy with the GLOW, and we look at the FL to increase our sensitivity to actually check we don't miss anything. And you see here, it's very stagnant. It doesn't mix with the blood, so we are confident the AVM, the dural fistula has been excluded. We do an angiogram, again, to verify. So we did 4 patients. We used GLOW800 in 3. Once we had a problem. So we had a problem, and actually that's an interesting case I want to share with you. It was not a technical problem. It was a biological problem. And it's a patient that actually had a foramen ovale, and he had a strong foramen ovale. So that actually when we injected the dye, there was a shunt, a left to right heart shunt, which was actually decreasing the concentration of the dye, and so the fluorescence were too tiny to be useful. And this is something now we check. If people have a shunt, we know that we need to increase the dye concentration, the injection, and we know that sometimes the ICG is not the best technique. And so there is a problem with arteriovenous shunt, heart shunts with ICG. And so it's fairly useful, but by itself, GLOW800 is not, in my eyes, sufficient. We need an angiogram to be sure that everything is correctly excluded. And here is an example of a bypass to show you how nice it is to have glowing through the arteries. So here you're going to see the graft on the left. You're going to see the parietal branch, which is actually synchronously feeding with fluorescence. And you see that there is no leakage. You see that it feeds correctly the brain. You see the temporal lobe, which gets green at the same time. And you can do that before and after to enjoy the fact that you nicely reperfuse the brain. So we did 2 patients, and it was useful in both patients. And I think here it's very clear that it's not only nice to see, but useful. So in conclusion, I would say that ICG injection and GLOW800 is extremely useful. It's really interesting to be able to see where the vessels are getting fluorescence, to understand the anatomy better with the context. It's accelerating, I would say, the surgery, but by itself, it's not sufficient. There are some few little issues you need to know, and I really recommend to always check, double check with FL mode after having seen with the glow mode, to be sure that you're not missing something. And it can help you seeing very faint signals or very small signals you might not see in the glow mode. So thank you very much again for Leica to organize this symposium, this summit, and thank you again for the interest you have in listening to that talk, and I'm very happy to address the questions.
Thank you so much, Professor Bijlenga, to being with us again, and thank you for sharing these extremely interesting insights into your daily work. Thanks a lot. So we will be getting to the questions in just a moment, but before we do, let's take a look at the supporting Leica technologies for aneurysm and AVM surgery. Those are the RVO Digital Augmented Reality Microscope, the M530 OHX microscope, and GLOW800 Augmented Reality Fluorescence, GLOW3D. Thank you so much, and thank you, dear audience, for your time, for your attention, and of course for your questions that you submitted. And we will take a look at the questions now. So let's see what our first question is. How well does GLOW800 correlate with the preoperative imaging?
Well, it correlates extremely well, and it's even better because on the preoperative imaging, the small vessels are not visible. So what you can see with ICG injection are very tiny vessels you cannot see on angiograms. So it has a higher resolution because you magnify with the microscope. It gives you another information. So if you look at the preoperative imaging, you have a good understanding of the anatomy for large, medium, and small vessels, but you don't see the very small vessels. And you have with angiogram the dynamics, and you see how the flow is going through the AVM or through the vessels in general. Now, with GLOW800, you have a better understanding of what's going on during the surgery. So you have your surgical point of view, you have a higher magnification, and actually you see that what you expect is what you can expect from pre-operative imaging is correlating very well. So you have a positive check, and you can see even more smaller details. So and the other big advantage is whatever you do, whatever impact you have on the blood vessels, you will immediately being able to see the impact you had on the flow. So if you put a clip, or if you coagulate a vessel, or if you resect part of the AVM, you can do an ICG again, and you can do many ICGs, 5, 6, 7 ICGs in a patient during an operation, and you can repeat it and see how you evolve into drying up the pathology. So that's true for aneurysms and AVMs and neurofistulas.
That sounds fantastic. Thank you very much. Next up, our viewers would like to know how important is intra-op monitoring in aneurysm clipping surgery?
Well, I would say if you bought a new car, you most probably have a beep announcing you when you might touch or when you're close to any obstacles. So I would say neuromonitoring is the same thing as this beeping or this warning telling you how close you are to structure and when you might hit structures. So it's a warning, and we use it for every case, but it warns a few times, and it's only useful, 100% useful, when it prevents an injury. When it prevents you hit something, you're able to modify your strategy, and you end up seeing that it recovers. So it's a warning, and I think it's a safety tool, and I think in our centers, it's mandatory for all cerebrovascular diseases. It increases the safety, and it's only useful when you actually prevent an injury.
Thank you very much. So then let us take a look at the next question. Dear Professor Bijlenga, thanks for this nice webinar and cases presentations. I can just agree. About AVM resection, what is your opinion about quantification of blood flow to better define what appears first and at the end give a true value, volsect arteries and veins before and after surgery?
Well, thank you very much for that very important question. And for me, it's extremely important to have that information. I actually look at the time and I see the dynamics. Some providers of technology can actually show the time with different scales of colors. So it's a useful tool, I think, to know the timing and to know how the dynamic is changing over time when you operate on the AVM and when you go through shutting down one feeder after the other. Now, having a quantitative value I think is extremely demanding, and I think that relative values are the next step, and I think they're already very interesting. Now, I even would be more interested in something else, which would be actually to know what's the oxygenation of the blood. So the blood, the hemoglobin, is fluorescent, and we all know that because we have devices that allow to measure the saturation of the blood on the fingers of the patient. So the idea would be to project actually the oxygen saturation of the vessels, of the blood in the vessels, and this might be even more important because it will allow us to see which brain regions are suffering from ischemia or from steel effects. So this will bring us a new dimension. So I'm waiting for that technology, and I would be very interested to see those vessels fluorescent by themselves without needing the injection of ICG and having this time accurate quantification of the oxygen saturation.
Oh, thank you so much. Then next up, what's the impact in terms of time added to the surgery overall of all these technologies? Which ones do you believe are really essential in everyday practice?
Well, once you train the people and once you really use it daily, it doesn't add much time. We actually checked, and I think now we can install and we can start the surgery within 15, 20 minutes. So it adds maybe 15 to 20 minutes to the operating time to set everything up, which is not much more than actually the installation of the neuromonitoring. So doing the neuromonitoring and doing and installing everything is not adding much to the surgical time. It's adding a lot of safety. And I think that nowadays that we really want to give the best safety to patients and the best results to patients, I think we need to be able to integrate all those technologies together. So I really highly recommend the people to adhere to it and to make the effort to get trained to it and use it. The benefits using those technology are enormous, and I think patients deserve safety. And I think it's on our hands to make it available to every patient. Now, which one is the most important one? I would say the gold standard. So for me, the hybrid room operation, the ability to make a check with an angiogram, with a high-resolution angiogram at the end of the surgery is nowadays the most important tool we have. Now, there is here an economical issue. I think hospitals need to have a relatively high amount of patients treated with those diseases to afford having those environments. And I think this is an organizational problem, a national problem. And I think neurosurgeons around the globe should address that issue. And if they want really to perform a safe surgery, they need to proceed and integrate those technologies.
Well, thanks a lot. Okay, then let's see. Next up, the question is perfusion pressure breakthrough a real phenomenon or a result of a left of nidus?
Who knows? We actually we were facing more breakthroughs, hemorrhages before than now. So I think our surgery has improved. And as our surgery has improved, we actually have less of those phenomena, less of those bleedings than we had before. I think very large AVMs, high flow AVMs, there is very large veins, might suffer what we call perfusion pressure breakthroughs, but also thrombosis or uncontrolled postoperative thrombosis of vein. So we might actually have also deep venage hemorrhages due to those big veins which thrombose after the surgery within the few days. So we now tend to keep people under heparin when we have those big veins for a couple of days, 2, 3, 4 days, to actually reduce the likelihood of having those venous thrombosis, which might end up in venous infarction and bleedings. Yeah, we all think about those high pressure breakthrough hemorrhages, but we see them less and less. So that makes me believe that those are actually phenomena or bleedings from remaining niduses.
Okay, thank you very much. Then let's see what our viewers would like to know next. Sir, can we leave a bit of remnants at neck or not?
Well, that's a philosophical question. We are pressed under pressure by the endovascular people doing very good job with stents, coils, and balloon-assisted coiling, stent-assisted coiling. So I think patients deserve to have the best treatment. Theoretically, we should not leave any remnant. In my experience, every remnant we left 5 or 10 years later grew and needed a second treatment. And one of the advantages of surgery over endovascular is that actually the need of a second surgery is smaller in surgery than endovascular, and we should keep that advantage. So I think that we should do our best to actually remove a remnant, to not leave any remnant, and we have that policy in Geneva since about 10 years. Before we had the hybrid room, we would even go operate a second time once we did the postoperative angiogram to remove all the remnants. So I think this, if we see something, we really seek for perfection. Now, in very complex aneurysms where we have hyperplasia, calcification on the neck, we have to balance the benefit of a complete treatment, removing all the remnants, and the risk of a stenosis and an ischemia and maybe a stroke. So here we need to balance the benefit and risks. And here usually the patients are fairly old and the stakes are not the same. So here we just have to use the common sense to find an optimum.
Okay, well, thank you very much. So then let's see what we have next up. Excellent presentation, Doctor. Many thanks for sharing your experience. Yes, I would also like to thank you. From your experience, what has been the greatest benefit of using RA and GLOW, probably AR and GLOW800 during surgical procedures? Have they allowed a reduction in operating room time?
Those techniques are complementary. The augmented reality improved the understanding. So it's increasing the surgical comfort and it's increasing the surgical safety. and it's reducing the invasiveness. We don't need to open as much. We can actually have more direct trajectories. And for teaching purposes, also for communication, it improves very much the workflow. And I think the orientation of the scrub nurse, of the assistants, and of the students is much easier and much quicker. So everybody has a much better understanding of the situation and the way you're going through the operation. So that improves overall, I would say, mainly the quality of the surgery, the quality of the result, and the safety of the procedure. Now, GLOW800 facilitates because you grab a better understanding quicker. So it's improving the workflow. So your concentration is less altered. So overall, I think it makes the operation smoother, much less stressing than before, and you keep a better control. So you less frequently exposed to situations, to unexpected situations. So overall, it's really increasing the safety. And I would say it's more or less like walking blind in the corridors or opening your eyes. Once you open your eyes, you actually can travel through the corridors much easier and much safer than when you walk around eyes closed, where you might bump into structures and hurt yourself.
Well, thank you. That's a very clear image, definitely. So we have time for one last question. Let's see what that one is. When comparing the AVM pre versus post resection with GLOW800, how important is it to you to have the exact same angle, magnification, and focus for exact comparison? Do you use navigation to reach this exact comparison, or are you doing it via manual positioning of the microscope? Interesting point also.
Thank you very much for this remark and this question. I actually position it manually. As I know where I look, I don't think I need to have exactly the same position. And I think we can actually look at the AVM under different angles. And definitely I looked in the cavity, so I use and I travel around to look at different angles, not to have the shadow effect, to be able to see everything around. So no, I don't position the microscope perfectly exactly always at the same position. Also, we could do, because the microscope is motorized, and you can record the position, you can record the trajectory of the microscope, and you could actually do perfect replicates from the same point of view. I never did it. Maybe I will do it now. I think it's interesting for presentation, because you can then show pictures of the AVM before and after from exactly the same angle. So it's nice to show. I don't think it's extremely useful. Anyway, we trust the angiogram most. So we have this, and we trust the angiograms time sequences more than the 3D angiograms. So we really look for early vein drainage, early veins on the angiograms to assess the resection of AVMs. But the GLOW is very useful because it allows to have an immediate answer, which is very reliable, because we actually never had to come back after the angiogram since we have GLOW.
Perfect. Well, thank you very much. Thank you for your fantastic answers, for giving us more detailed insight and for diving into the questions. And of course, thank you again for this great presentation and for again taking the time out of your very busy schedule. We appreciate it highly. Thank you, Professor Bijlenga.
Thank you very much for the invitation.
And of course, also, dear audience, thank you to you. Thank you for your time, for your participation, for your input, for your great questions.